Hello, everyone. I'm Denise Resnick, President of Skyline Trails Associates, and I appreciate each of you taking the time to join us today. As you know, we are extremely disappointed to cancel the beloved Associates Luncheon in March due to COVID-19. The many expressions of encouragement and understanding have meant a lot during this time of uncertainty. Thank you. I wanted to take a moment to share my tremendous gratitude for our event sponsors and table hosts. We appreciate all of you, especially amid these turbulent times. The recent upheaval of our society and economy is impacting rates of depression, anxiety, and other mental illnesses. In response to the pandemic, Skyline Trail had re-engineered its programs to serve as clients and families in person and virtually. Fortunately, they have been able to continue to provide care for those depending on them. However, increased demand in services is also coinciding with increased need for financial support for families navigating a shifting economy. Now more than ever, we thank you for your support of Skyline Trail and for standing with individuals in their journey toward recovery. We are also especially grateful to our speakers, Margaret Sisson and Dr. Ben Hunter, Skyline Trail's Medical Director of Outpatient Services, who you will hear from shortly and who donated their time in support of our mission. If you're not already a member of the Associates, I encourage you to consider joining to support Skyline Trail and the important work they do in our community and beyond. It's such a great way to make a difference in the lives of clients and their families and to promote the conversation about mental health. I hope you'll stay connected to Skyline Trail via their website to learn more about future associates, events, and how you can support the Skyline Trail clients and others struggling with mental illness. Stay healthy, stay hopeful, and please continue to stay connected to one another during this time. We will get through this together.
Well, thank you for joining us. My name is Ben Hunter. I'm a psychiatrist and the Medical Director of Outpatient Services at Skyline Trail. I'm joined here today by Margaret Sisson, who's been kind enough to join us and will walk us through the journey that she had dealing with mental health issues with her son, Riley. And thanks for being with us today, Margaret.
Thank you, Ben, for having me. I am Executive Director of Riley's Wish Foundation, which I named after my son. He struggled with OCD and substance use, and unfortunately, I lost him 5 years ago. So that is what I'll help. I want to help families not go through the journey that I did with Riley, and I hope between Ben and myself we can help some families today.
Margaret, maybe it'd be best if you start out by telling us a little bit about Riley and the way his mental health journey began and how it evolved.
Yes. Riley was diagnosed at 12 years old with OCD. And I emphasize was diagnosed, but probably it started earlier than 12. There wasn't a lot of recognition of what it was at that time. And finally, my father, who was a pediatrician, who diagnosed him. That was Riley's story. Riley was a super bright, fun young man that was actually tortured with this OCD, and despite that, made so many incredible strides in from his education. He was salutatorian of his high school. Was asked to go to Davidson for football, and obviously a very well-known school academically. But as time went, the OCD got worse. There was not help for him there, and then the substance use increased, and it became a vicious cycle. The last thing he wanted to do is struggle with substance. He was embarrassed. He had so many goals that he wanted to reach. He wanted to be a counselor, go into social work and help other people. So that's a little bit about Riley.
Yeah. Well, thanks for sharing, Margaret. That's such a common and, unfortunate dilemma we have to deal with, which is managing what we call primary mental health issues like OCD, obsessive compulsive disorder, along with comorbid or co-occurring substance use. Because as you mentioned, the phenomenon of self-medication, especially in the setting of anxiety and depression, is so prevalent. So I think that's a really important point to bring up, and I'm glad we'll get to talk a little bit about that today. You mentioned that Riley was first diagnosed when he was 12, and that maybe he had been experiencing symptoms prior to that. It's always so hard to know, when something crosses over into the realm of becoming a diagnosable issue that needs to be treated medically. But were there things, looking back now, obviously with hindsight that no one would have in the moment, are you looking back, are there things you recognized before he was diagnosed, and other things you would have cued on after eventually realizing what his diagnosis was?
And that's a good question, because obviously I've gone back many, many times. I think maybe I did, now I look back, I can recognize some of his behavior. Riley was a super kind, and his OCD was wrapped around not hurting others. And so I look back in some of his behavior, he would get very upset and worried if he had hurt someone's feelings or he'd hurt, and then would, is it okay? And, wanted that reassurance. Well, and I emphasize to families, it's everything a parent's, you're taught to reassure your child and things are okay, and which just feeds into that OCD, that reassurance. So yes, when I look back, I look back at a particular time when he was 11, turning 12, going into camp, that he'd been in a camp for 3 years, and, would wave and say goodbye and say, you guys going to be okay? And we, reassure. But this one summer, after the third summer, he was really anxious about going. And when he got to the camp the first night, they called me and said, we usually don't, we have children that are homesick, but this is just a little bit different, and we're worried. And I said, well, let me talk to him. And I said, Riley, camp's supposed to be fun. If you feel this way in the morning, I'll come get you. Because he was just at a state of almost panic. And then the counselors took the phone away from him. And as the morning came, they called me, and then he was physically sick from the anxiety. And so I went and picked him up. And that was the summer where I said something. And once he started 6th grade, he was throwing up every morning. He'd get to school and he'd continue his locker, which that's a 6th grader worried about whether their locker, but his was obviously more. And the counselor said, so I went to the counselor and I said, something's not right. And they said, oh, it's just anxiety about, a little bit about, moving in from elementary to middle school. And I said, no, something's just not right. This is more than just anxiety of moving into. And that's when I discussed it with my dad and told him, and he was the one that diagnosed him with OCD. And so that was 25 years ago. But we didn't have what we have now. And we didn't have the recognition of the therapy, what can help. And so there we go. So we went through school. I never did an IEP because he didn't want that. I mean, he was so embarrassed of it and he's so bright that, as you'll see, many OCD, very bright. And so he learned to, teachers loved him, and I would wait, about 2 weeks, and I'd have a teacher would call and say, oh my gosh, your son asked these questions that nobody else will ask. And well, I knew what it was. He was asking for reassurance. And so I would just meet with the teachers, and I said, this is what's going on. Here's some tools if to help them. Because that's kind of all I knew what to do, because nobody was giving me much advice. So
you've basically got a sensitive kid, and without any real obvious obsessions and compulsions, sort of the outward ones that we can most of the time recognize, maybe even at an earlier age. I want to say that you guys did a pretty remarkable job of picking up on this anxiety that, again, we would have been especially normalized 25 years ago. I think this was not something we would have been thinking about as OCD. And like you said, it's sort of a separation anxiety or mild age-related, kind of age-appropriate anxiety. And at some point, though, you realized it was causing him distress and also causing some dysfunction, it sounds like, at school and, socially with camp and maybe in other settings. And that's when you started to realize maybe it was more than just the typical childhood anxiety.
Yes.
At what point did you say, and maybe this was conversations with your father and maybe some of the school counselors and teachers, at what point did you say, it's time to go see a professional, and what helped you make that decision?
That was 6th grade. As we got into, I'd say 3 to 4 weeks. And my dad had recommended that we go see somebody, but be honest, back then, I don't even know ERP was, so it was just talk therapy, and it was reassuring him. And, that's what was there then. So, it really wasn't till his senior year in high school that I found a therapist that was trained with ERP, and I would drive all the way. I live south of Atlanta, and I'd drive all the way to Lawrenceville 2 to 3 days a week, because he was determined to go off to Davison. He'd been accepted. And and that's when it started. They started working with the ERP. Well, be honest, I'm not sure I knew how much the substance use had already been playing a big part by 18. And my determination was, was he healthy enough to go off to college? And he was so determined he was going to go off to college. So I feel like we got him I feel like we got him in a place that he could go off, although you get off to college and drinking and fraternities are a big part of the college scene. And Riley, I'm not sure, did it so much for social, but to stop his brain. And I mean, stop his brain to where he'd want to pass out, and then he wouldn't have to deal with it. And it became this exhausting cycle of the OCD, and then being the student he was and playing football, that, he had to keep that Monday through Friday or Saturday until the game. And then, and so eventually after a year, he made the decision that he wasn't going to play football. He wanted to concentrate more on his academics. So he transferred to University of Georgia. And that's a pretty toxic environment if you struggle with addiction. And so it just continued. And there were some tough things that happened there. So, and to where we had to deal with the court system. And Riley made the decision. I learned through the New York Times, I think, reading there were 3 programs, collegiate recovery programs in the United States, and one was at Kennesaw. And so that's where Riley eventually went. He was part of their collegiate recovery program. I mean, I think it kept him alive through school, and he worked, and he actually then went back with the director to University of Georgia and was the spokesman to start their collegiate recovery program. So, you know, with your families, with any families, excellent program at Kennesaw. Cannot even say how, because I know that saved his life for a while. And he was 2 weeks into his master's program to be a counselor. And Ben will talk, because we've discussed about medication. Riley was on some medication, but each time he would go back into, he would relapse would be when doctors would put him on Klonopin, a benzo. And once he was on that, it sent his brain into that addiction. And that honestly that's what happened at the end. Put him back on Klonopin to ease his anxiety. And not that there aren't medications but that's where a therapist and a doctor needs to be really aware of what their patient, it's the whole patient. And it's not just looking at the OCD and the addiction and the OCD and the anxiety, because yes, Klonopin will treat that anxiety. But if you have someone with a propensity towards addiction, then that can be a nightmare, as my story says.
You brought up a few really important points there, Margaret, and you know, such an important age, and you know, that kind of emerging high school into college time when so many social and physical and, you know, honestly mental changes are happening for people. Just to clarify for anyone who's a little less familiar with OCD and its treatment, obsessive compulsive disorder is an anxiety disorder that is really marked by intrusive, anxious thoughts that oftentimes seem irrational, but at the same time can't sort of be packed away and dealt with easily, and they tend to recur and really torment people over time. And again, oftentimes they're linked to sometimes the morals and the values and the things that people hold very dear. Often, for example, mothers who love their babies more than anything in the world fear that they may harm their baby. And what we think is that, again, their deep desire to love and care for their baby, for example, generates a very significant fear that anything negative could happen to that baby. And therefore, the brain kind of morphs that into a fear of harming the baby. So you can see how many times with obsessions, and I imagine Riley, a nice, caring young man who was very concerned about the well-being of others, was actually in some ways so scrupulous and in so many ways so concerned about others that it actually morphed into a fear that he might harm others. And
right. OCD will latch on to the things you love, and that's what your brain will do. And thank you for the intrusive thoughts, which some people are not knowledgeable. You know, most of you think OCD, obsessive compulsive, is somebody that washes their hands. That's how Riley started in 6th grade. And that was another thing when we started. When I called my dad, he asked me, he said, well, does he wash his hands? I said, yes, he washes his hands. They're raw. I mean, almost bleeding. And so that's how that was what it started. That morphed into so many different compulsions. There were outward compulsions, but he also had intrusive thoughts that you wouldn't, you know, and some people just have intrusive thoughts that you wouldn't even know. And as you say, you know, intrusive, there's religious, sexual, harm reduction, harming others, and horrendous things that get caught in their brain and they can't let go. And so it's torturous. And I always say to parents that I help along the way, and I talk to a lot of families who educate yourself, understand because there's parts of OCD that have a lot of shaming for the person. And so if you educate yourself and understand whether for your loved one, whether it's a child or a young adult or an adult, don't think that these thoughts are horrendous that they are thinking and makes them feel awful. So when you talk about dual diagnosis, depression oftentimes comes with OCD, because when you have a thought that you cannot get rid of, and it makes you think things that you would never, like Riley would never want to hurt or harm someone, but that's a continuous in your brain and you can't get rid of that. So what do? Maybe you self-medicate yourself with alcohol. You struggle with a depression because it's a hard way to live. But there is hope, and that's where you and I have talked a bunch, that the therapy is so very important. Medication alongside, but knowing your patient, if they struggle with a substance use, you've got to be aware of that.
No, that's a really important point. And, you know, you brought up, again, a great point to discuss, Margaret, which is that, again, the types of intrusive thoughts that people will suffer from oftentimes, number one, feel very upsetting to them personally, and they're embarrassed and ashamed often. Again, you know, concerned that you might harm someone else, or you know, those types of harm-related intrusive thoughts, often very difficult to come out and tell parents or friends or guidance counselors. It's just not the type of thing most kids feel like they want to be talking to their parents about, because, again, they sort of relate that to violence and maybe all the things they've taught not to engage in. And at the same time, they can't understand why these thoughts continue to come into their mind. And oftentimes the very effort to remove and banish these thoughts from someone's mind is what perpetuates the cycle of again, intrusion, and kind of keeps them coming back. It kind of feeds that mechanism, so to speak. And the greater the fear of, again, having these things happen, the more they tend to come into one's mind. And I think it's really important to point out too that people with OCD are not at an increased risk of harming others, or, in other words, acting on their intrusive thoughts.
Exactly.
That is something I think that maybe, again, the public may not understand quite as well, but having thoughts about harming others oftentimes puts people so on guard against harming anyone, sort of like Riley was. He was almost overly caring, and he needed reassurance that he wasn't doing anything that would harm someone. Mothers who have intrusive thoughts about their babies are not at a significantly increased risk of harming their babies, and again, often turn out to be fantastic mothers. And
absolutely.
So I think that's an important point. And, you know, you mentioned also, I think, one of the other kind of colloquial notions about OCD, that you have the obsessive thoughts, the O of the obsessive compulsive disorder. Then you have the compulsive behaviors, and behaviors can be physical, like hand washing, or the other ones people hear about are checking door locks repeatedly, turning off the oven or checking the oven repeatedly to make sure that's not left on, things of that nature. They can also be mental, counting, going through prayers or other sort of special sayings that help reduce anxiety. But essentially, these compulsions are designed to, again, combat the level of anxiety that's grown as a result of these intrusive thoughts. So often, and someone, you know, in Riley's case, might have a thought about you know, being dirty or becoming ill, and his compulsive response might be to wash his hands repeatedly to make sure there weren't any germs, or otherwise he wouldn't become ill. So there's this, you know, both of those symptoms can classify someone with OCD, but often you see both. You see an obsessive thought, an intrusive thought that's then accompanied by a behavior to help reduce the anxiety. And at a certain point, I imagine for Riley, it became so exhausting that, again, you look for more long-lasting approaches to managing the anxiety level, because, you know, washing your hands might only last for a few minutes till you touch another surface and have another intrusive thought. So things like alcohol or other drugs might enter the picture and help people feel at least maybe a few hours of relief. And oftentimes, even if they know they're doing harm to themselves physically, it's sort of worth it in some ways to get a few hours of relief, which again is why it's so important for us to talk about, the medical options we can use. And
Right.
that's probably a good segue, Margaret, to discuss also and you mentioned ERP. So again, for anyone who hasn't been familiar with OCD treatment, and exposure and response prevention or ritual prevention therapy, ERP, is a gold standard psychotherapy or talk therapy modality that's based around using small and gradually increasing exposures to the feared outcome. Again, whether it's someone who has contamination fear and getting them to gradually touch more surfaces and expose themselves to more everyday types of exposures there, or confronting ideas that, again, cause distress in a psychotherapeutic setting where it's guided by a licensed therapist. What we see is that by gradually exposing the brain, again, in controlled amounts to the stimulus that it fears, it actually reduces the person's level of anxiety when they experience the same stimulus moving forward. Experiencing those emotions fully and processing them ultimately leads to the reduction of the intensity, as opposed to kind of packing them away and avoiding them.
Mm-hmm.
But it's really important to be sensitive to those people while they're going through therapy, right? And to be watching out for any signs that it's going a little too intensely.
I remember someone telling me way back, so to help me understand, as a parent, they said, you have your 2-year-old and you're in a shopping center and your 2-year-old gets lost or hides, and you have that horrendous feeling, that anxiety of, in that moment before you find them, there's that horrendous feeling. And that relates to kind of what somebody with OCD, when they're worried whether their truck door or, they've left the water on, etc. That's that feeling. And so the brain is very powerful and to make you feel that way. And that helped me, and as a parent, to understand, because I'm not going to tell you there weren't some really frustrating times when I stood at a door with Riley and we couldn't go anywhere, and we so to have that patience and understanding. And that's why I tell family members, OCD is a family disease, and you have to be educated and understand it. And that helped me to understand, if that's that feeling they're feeling, because that was, that happened to me, and I had that feeling, and that helped me understand, gosh, this is what, when he's standing at the door, when I'm like, we got to get somewhere, but that's what his brain was telling him, and that was the feeling. And I mean, he'd physically sweat, and but what if? And so if family members hear this and their loved one is dealing with this, I also recognize it's difficult, but if you can understand your loved one and educate yourself and understand what they're going through, and educate yourself on the treatment and everything that Ben's been talking about. I mean, if you will educate yourself about how to get your loved one help, that's what it's all about.
And it's so critical to acknowledge that families go through so much, and just as a blanket statement, I think families and the problems families face can be so challenging. And I think the worst thing we can do is make anyone who's working with a child with mental illness or a family member with any mental health issue feel ashamed of the natural frustration and some of the challenges that come up as a result. And I think in many cases, feeling ashamed and feeling silently frustrated often prevents people from reaching out for help, because again, they feel like they shouldn't be frustrated by a child who they love so much, who's, going through issues, and that, kind of admitting defeat in that sense is a sign that they either don't care enough to manage it themselves. We know nothing could be further from the truth.
Right,
and,
right.
That's the support that every family deserves. I mean,
Every family, yeah, because a parent starts to, then you feel, the guilt and the shame. And so along with the child or adolescent being treated and getting therapy, the family has to have work with somebody in order to understand those, have tools in order to understand what's going on.
right.
Super important.
And you reached out, at some point, Riley was in therapy, and then also a psychiatrist entered the picture. So you had a actual medical doctor seeing him for medication treatment and other forms of treatment that were considered along the way, like Skyline Trail. Can you tell us a little bit about that decision, Margaret, and kind of how the psychiatric treatment that Riley was able to access helped with his symptoms, or otherwise sort of moved his treatment along?
Yes, because each day I learned something every day about and felt like medication is a important part. Some people don't need it, some do. And he was on an SSRI, and I'll let Ben, the doctor, will be able to tell you more. But and then we went back to the benzos, which that never worked. So he was on an SSRI that would help him, and was always on that. And with OCD, as you'll explain, it needs to probably be a higher dose. And felt like that helped him along with the therapy. And at first, to be honest, it was just medication because we didn't know about the therapy. So the combination of the two are very, I think, beneficial. Not everybody needs to be on the medication, but in Riley's case, it did help.
Yeah, that's a great point to bring up. We think about anxiety disorders and OCD as being, obviously on a spectrum of severity, and at the lower end of the severity spectrum, you may end up with anxiety levels that can be managed through psychotherapy, primarily, even without medications. And again, in the treatment of OCD and anxiety, we know that medications are effective, and particularly that gold standard class of medications, serotonin reuptake inhibitors, the ones we've all heard about, like Prozac and Zoloft and Lexapro. And then also psychotherapies are evidence-based. So each one independently is evidence-based to treat this issue. And we know that in a combined sense, they're typically more effective. So maybe someone's not at a severity level where they need medications yet, but in many cases, once it starts to impact functioning significantly, we provide medication therapy to put a floor under their feet, so to speak, to relieve their symptoms enough that they can do their therapy to the highest degree. And I think there's a lot of misconceptions about pharmacological therapy and using medications to treat mental health issues. As a psychiatrist, this is probably what I get brought in to do the most in kind of a unique sense, given that it does require that level of licensure. At the same time, I can tell you that I still view psychotherapy as the core element of mental health treatment. And I think about medications as a way to really enable the best psychotherapy to happen. I hope that all my patients continue to do psychotherapy as long as they possibly can to, again, promote insight and growth in addition to just symptom relief. But, in Riley's case, he needed some medication, it sounds like, to even allow that anxiety level to be reduced to the point that he could do good exposure therapy, especially a therapy like exposure therapy, where we know anxiety levels can actually increase initially as a result of the therapy itself.
Right, right.
Did you experience any, I would say, resistance either internally from Riley or from your own kind of thoughts about medication management, or from other people, other families you were interacting with, or friends who said, are you really going to put your kid on medications? And
that's the interesting, and as a teacher and a school administrator, I deal deal with that with a lot of, I think there is a place for medication. Is that your very first? Maybe not, but I certainly believe there's a place for medication. And in Riley's case, I think that it was beneficial for him. He felt the SSRI was beneficial to him. When he got really bad, they started adding just everything to where he described himself as a soldier walking around with no thoughts, and he hated that. So they added a lot of things that did not help, and then he'd say this isn't helping, and so they'd increase the dose, and then it would, So that's the important part of a good psychiatrist that understands their patient, and like I say, Riley was not resistant. He wanted to get better more than anything. So and at first he'd, okay, try that, because I want to get better. So I solely believe there's an important part of that. Medication is an important part, but just like you said, Ben, I think the therapy is the gold standard that is so important too. And so when you combine the two, I think you're in a good place to help people.
That's, this should always be a collaborative approach. And I think that one of the things, people can look for, whether they're dealing with their own issues or for a family member, is that a psychiatrist or any other professional, including therapists and others, is willing to sit down, understand what the patient and family want to use and what their priorities are in terms of, again, the way they're going to feel, the types of approaches they're going to take, and how that might affect their overall health. And again, we know medications are processed through the body, and while being very safe, they are occasionally prone to having side effects, and you want to make sure you're listening for those side effects and choosing a medication that minimizes that for patients. I think sometimes we have an idea of what will work and we lean towards that. And I think, the important thing is to, again, have that be an open, ongoing conversation with family and patients, so that, again, if it's not quite fitting, we move on and we find something that's more effective and more tolerable. It's a trial and error process, as you probably saw with Riley, Margaret. I think, in many cases it takes really anywhere between 1 and 3 or 4 on average medication choices before we achieve great results. And oftentimes it takes a significant amount of adjustment to the dosage as well. And I think one of the things we tell families and patients primarily is to maintain some patience with the process, so to speak, to allow us a little bit of time to work on adjusting the dose and choosing the right medication. Oftentimes patients with OCD and other forms of anxiety do require a higher dosage of medications like the SSRI class. And sometimes that can be frustrating for patients and families as they wait through multiple dose increases to eventually reach the level that's effective. So we really have to help educate patients and families to bear with the process. And again, a lot of times it may take even up to months to get the dose just right, but we're hopefully making progress along the way.
Right. And Ben, I emphasize importance, and you kind of touched on with a therapist and a psychiatrist. Obviously in a residential facility, if someone's in a residential, you will have that collaboration. But oftentimes that doesn't happen when someone starts seeing a therapist and they're seeing their psychiatrist, and they don't work as a team. And that can be detrimental to the patient, because a therapist might be saying, this is what we're doing ERP. And if the doctor, whether they're knowledgeable on ERP, but it's just medication. So I think that's really important how we, and you guys do a great job at educating the families to understand and be your child or your young adult's advocate, that has to be a team. It has to be the psychiatrist and the therapist working together, because that's what's going to be the best for the patient.
You should see outward evidence of them working together. You should hear them talking about conversations they've had with the other. I think that's typically what I'm looking for when I talk to to psychiatrists, I'm wanting to hear if they're touching base with a therapist. There's so many things that can be examined and uncovered in the therapy process, where you have often an hour a week to talk with someone, that are hard to get in a 15 or 30-minute medication, check appointment with a psychiatrist. So yeah, to be in regular contact, and obviously here at Skyland, we're in constant contact, given the fact that we work directly together with all of our patients with a therapist. But yeah, a great thing to look for if you're choosing a provider is someone who's very invested in that person's psychotherapy, as a psychiatrist, very invested in that person's psychotherapy as well, and who knows what their therapist's name is and has talked to him hopefully within the last couple of months.
Exactly. I mean, that's, to me, kind of a simple but so very important in treating someone.
Yeah, I think we've covered a lot of ground here, Margaret. I think there's so much useful information, and again, I so appreciate your sharing Riley's experience. And I think we'd be remiss if we didn't just talk for a minute about, again, the experience for you, and you've outlined some of the challenges for you and your family and helping support Riley. But I wondered if you might talk for a moment, Margaret, about the importance of prioritizing your own health too, and your own wellness while, dealing with a family member's mental illness, and, kind of maybe some ways that you were able to achieve that and find some balance, despite the fact that, at times, I'm sure Riley's mental health issues were really placing a strain on both him and the family.
Yeah, that's a very good question, because probably I didn't at first. But I think I love to exercise, and it became so important in my health. And I'm so grateful and fortunate I have horses, and that's something that I love and enjoy. And, I would be dealing with Riley and hospitals and insurance, and so I wouldn't ride, but I realized that's going to be important, because if I'm not healthy and I don't take care of myself, I can't take care of him, and I can't make good decisions, and I can't, because it was a constant making the right decision. How could I help him? Where, to educate myself. So I learned to take care of myself, and it's okay to take care of yourself. And matter of fact, it's so very important to take care of yourself. So I think for any family member dealing with it, because it's stressful, it's consuming, and if you don't take time to self-care, be honest, you're not going to be there to help your loved one. So super, super important. And I think, like, exercise for your loved one too. I think exercise is, I don't think we talk about that enough, because I really think exercise is super important for somebody dealing with this too.
The medical data supports everything you just said, Margaret. And I think every month and year we're coming out with more and more data to show that exercise prevents the onset and also helps prevent relapse into mental health issues, and beyond just being healthy for a number of other reasons and helping with people's general overarching wellness. It's such a positive thing to engage. And to your point, not only is it okay to get help, if you're a family member helping deal with someone with mental health issues, you will probably be the strongest support for that person if you are well yourself. And I think, that's a great place to start for most individuals who are wondering what the next step they can take is to help support a loved one with a mental health issue is, seek your own therapy and support, formally or informally. But I think I've encourage formally, if nothing else, it'll help you understand the process that your family member is going through also. And, again, all good therapists are trained to take an approach where they meet you where you are in the process. So if you're not interested in being diagnosed and treated with medications and, uncovering your own issues in that sense, no one's going to push you towards that. They're going to try and support you in whatever endeavors you need support in, like caring for your loved one. Maybe I'll conclude by asking you this, Margaret. I think it'd be different if I said it, but when's the right time to bring a loved one to a professional for mental health help?
That's a good question. And just what you said, I think the sooner, and that might be the sooner in age-wise, symptoms, the sooner you take them to and whether it be a residential or, somebody out of a residential, just a therapist, you're setting up a start, because if that person can start to learn the tools, how to deal with their mental health. And like you say, I think everybody, even a family member, don't think just because you aren't diagnosed with, if you aren't diagnosed with a mental health, seeking therapy for your own health, there is, just like you go to the doctor and, you don't just go to the doctor when you're really sick, you go for a checkup and check in. I feel like that's super important with mental health, and whether you're diagnosed with mental health or to go have a check-in with people and that are professionals and can understand. So I'm a big proponent of that.
Well, Margaret, thank you so much for your time. You've been such an advocate for the mental health community and for Skyland Trail, and it's our pleasure to have you on and have the time to talk to you about Riley and your experience in working through his mental health issues. Again, just really appreciate your time.
And thank you, Ben. And if someone's listening, I cannot say more better words about Skyland Trail and your program and what you offer. And obviously I was thrilled to see, you have an adolescence program for OCD and anxiety. And I went and toured, and it is just state of the art. And how lucky we are in Atlanta and around in the South and the United States that we have a program like Skyland Trail. I feel very grateful for that, and often recommend, and I feel grateful that you all let me do things like this so I can help families. So I appreciate you all.
Well, thanks so much, Margaret.